Hello, and thank you for joining today's webinar. We will be starting in 1 minute. Hello, and thank you for joining today's webinar. We are ready to begin. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, we will have time for a question and answer session. You'll see on your GoToWebinar control panel that you can send a message through the questions feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. To test out this feature, please submit the state or country you are from. On behalf of Sigma, we would like to thank our speaker for sharing her expertise with us today. Our speaker is Dr. Lois Marshall. Dr. Marshall has been a nurse educator for 40 years. While at the University of Miami School of Nursing, she has had a variety of faculty and administration positions, including teaching for 26 years. After teaching, she decided to pursue a consultative career in nursing education, evidence-based practice, research grants, and career development and management. She has received numerous awards for her teaching throughout her career. Dr. Marshall holds a BSN from the University of Miami, an MM from Emory University, and a PhD in higher education from the University of Miami. Dr. Marshall's doctoral dissertation focused on variables that predict success on the licensure examination for registered nurses, the NCLEX-RN. Dr. Marshall developed her own NCLEX review program focusing on unique testing strategies, linking and conceptualization to assist in meeting the studying and teaching needs of all new nurse graduates. She has traveled across the country and worked online to assist and mentor to students in areas of testing and licensure preparation. Also, she works with students internationally to prepare for the NCLEX-RN as they move to the States, as well as nurses from other countries that are currently living in the U.S. She has worked with new graduates and nurses from Cuba, the Philippines, Australia, and South Africa. Now let's go ahead and turn the presentation over to Dr. Marshall.
Good morning. It is nice to see all of you. Okay. I am very happy to be here and talk to you today about NCLEX. If you have been on some of the other Sigma webinars that have been for members, then this is a continuation of that. If this is the first time that you're on one of my webinars, then you will be able to catch up. And at the end, if you have an interest or you have something else that you would like me to cover, then please let us know that either through the evaluation, or you can drop me an email and let me know that these are things that you would like to cover, and I will be glad to make sure that we do that. I want to do as many of these as I can. We don't want them to be at any cost to anybody. We want this to be something that is a benefit to you and is different than a lot of the other board reviews that you're getting. So my board reviews are very specific to your test taking strategies and needs, okay, and how you take what you've learned and use it for as many different things as you can. And so that's what we're going to be covering today. It's not that you don't need to know content, and there is going to be content in the slides, but what is important is that you don't take a board review book and just try to read all the content over and over and over again, because you're going to see that you know so many things. If you use them critically, if you link them together, and you'll see that, I'll explain that as we go on. And if you conceptualize the information that you've learned from your individual schools of nursing and faculty, then you're actually getting the best use of that information. In lots of other board reviews, people are just going to tell you to memorize everything. But if you do that, it's going to take you so long to study for the boards that it doesn't give you the benefit of knowing and learning and utilizing what you've already learned. So that's what we're going to be talking about. So the best use of your study time, from my perspective, is to take practice tests. It's best if they're comprehensive, but any questions are better than none. So if you have a board review book or you have an online access to something, then use any questions if that's all you have. If they're all cardiac, that's fine. If they're all respiratory, that's fine. But the best way to practice is by using comprehensive tests. Okay? You want to start with the smaller number of questions and work your way up. Now, because all of you are new grads, so up until or through September 30th, as of right now, the boards has changed the way the test is being given. So instead of 75 to 265 questions, you're going to take between 60 and 130 with a maximum of 4 hours rather than a maximum of 6 hours. Okay? People ask me all the time, well, that's not fair. And what is that going to mean? Do I have to do better than I would have before? It doesn't make any difference. The psychometrics or the statistics for how they calculate your score is still based on the exact same thing, with minimal competency being the measure of your success. So it's important that when you're practicing that you start with like a 60 question test and take it. And then as you get closer to your board date, then move towards taking 130 items and make sure that you can sit for a 130 item test in 4 hours. Because the worst thing that can happen to you when you take your boards is that the clock ends and you haven't finished. So make sure that you do that. And those of you that are on the call know if you're a slow test taker, and that's okay. You have to speed up. And there are exercises that you can do to get better at that. And if that's you and you have a problem with that and you need some help with that, then at the very end, you can contact me and I'll be glad to share that with, different ways that you can do that. Okay. So that's the test. So when you're practicing, you want to say you're starting, today. And by the way, let me just mention to you, because a lot of people have been asking me this as well about the boards. A lot of people are trying to get test dates now. And I've had lots of students or new grads tell me, I can only get a date either next week or in September. What do I do? Okay, so I'm not a big advocate of people jumping to go take the boards unless you've been studying all along and you're ready. Okay, you feel ready. Your psyche is 50% of your success. So you have to feel like you can pass. So if those are the only two options, what I've been trying to tell people is if you don't feel ready, don't feel forced to take a date next week. Just sign up for the date in September and then get the number for the call center, where the Pearson Center or the Continental Center, where you're going, and then just keep calling them every day. And when you call them every day, they can tell you if they've had a cancellation, and then you can go and take your boards earlier. And I had somebody yesterday tell me that they had a date next week and now they got it at the end of June. So don't feel pressured to go take your boards if you're not ready. Okay? So when you're studying, take a 60 item test or whatever number you're taking. You want to grade your test. And what I mean by that is just which ones you got right and wrong. You don't need to calculate a score. Okay? You want to review all the items you missed and the rationales for all of them. And we'll practice with some questions at the end and throughout, and I'll show you how to do that. And then you want to use a content review only if you're still unsure. Otherwise, keep going. So you should not be reading board review books. It's the number one question I get asked all the time. Should I read a board review book? No, don't read a board review book. You already went to nursing school. You've graduated. You have a degree. You have a diploma. You're ready to go. You just need to become a better test taker, okay? A savvy test taker. So you want to use test strategies to practice when they're needed so that they become ingrained in your ability. So when you go take the boards, you don't have to think about them. So I always say, only use a test strategy, whether it's mine or somebody else's, if it's needed. If you know the answer, just pick the answer and go. But if you don't know the answer, that's when to use a test strategy. And remember, the computer does not care if you know the right answer. The computer does not care if you theoretically know why it's right or wrong. The computer only cares that you chose the right answer, and then it adapts and gives you the next question. So do I want you to know why everything is right? Of course I do. Okay, you're going to take care of people I know, and I want you to be a great practicing nurse. But that was the job of your faculty. My job is to make sure that no matter what, you can pass the test. So I may give you strategies or tell you ways to answer questions that may not make perfect sense in a theoretical world, but they'll make sense in a test-taking world, and that's the important thing to remember. And then lastly, don't overstudy, not by time and not by number of test items. People get told all the time from faculty and from other people that they know, you should be studying 8 hours a day. You should be taking hundreds of questions a day. You can't do it like that. It's what you do with the questions. I have some students that I tutor that I give them 10 questions, and that's what they take for the day, 10. Because we tear them apart and rip them up and learn why one answer is right and the others are wrong and how to answer it. So just don't be studying, for me, more than 2 or 3 hours a day. Okay, and you can break that up however you want, depending on how much you can sit still. But other than that, if you stick to the 60 to 130 as far as a number, and you stick to about 2 to 3 hours, that's great. And you should not be studying 7 days a week. Study 6 days a week, take 1 day off to refresh your brain, because you don't want to get to the point where you come to your boards and then you can't think anymore because you've just been so overwhelmed with everything. Okay, so that's important to remember. Okay, so we're going to start with practice question number 1, which is going to be on cystic fibrosis. Okay, there you go. So as the question is pulled up, for some of these at the beginning, just go ahead and answer it, and then we're going to discuss it. Okay, everybody should have answered it by now. There we go. Okay, so I'm going to go over this with you. And by the way, the things that we're discussing are what I call high percentage areas, so that you're not going to learn every bit of content that you ever learned in school if you're in any of my reviews. And remember, my board reviews are usually 8-hour days broken up, and so we're only here for an hour and a half. But I'm trying to provide you with information about high percentage areas, things that have the greatest percentage of showing up on the boards, meaning more of you have a chance of getting a question about it. Okay, so this one question is about cystic fibrosis, which is the #1 chronic disorder of Caucasian children. We don't really use the word children anymore because adults can have it, but that's why there's a high percentage on it. So the question asks, what discharge teaching should a nurse provide to parents with a child who has cystic fibrosis? Okay, the correct answer was D. So those of you that picked D, perform CPT or chest physiotherapy on a scheduled basis daily. That's the correct answer. Now, if you did not answer that, this is how I'm going to show you how to do it. And this is what you should be doing when you're taking practice tests and then you're going over them. You should be looking for why the other ones are wrong. So the first answer was genetic testing is not necessary since 1 out of 2 children already have it. Okay, remember that cystic fibrosis, just like sickle cell anemia, is an autosomal recessive disorder. So autosomal recessive disorders mean that both parents have to have the trait. Okay, both parents have to have the trait. This is also going to be on a slide, so you can just listen to me now. Both parents have to have the trait, and then there is a 25% chance with each pregnancy that they can have a child with cystic fibrosis. So if they have 4 pregnancies, they could have 4 children with CF, or they could have no children with CF. So it doesn't matter what the previous pregnancy, the product was. So again, there's a 25% chance that the child will have the disease. There's a 25% chance that the child will be normal, meaning no disease, no trait. And there's a 50% chance that the child will get the trait. And then that child is not sick. The only way that they can then pass on the gene or the autosomal recessive disorder is if they then procreate with someone else who has the genetic disruption or the trait as well. Okay, so that's the first one. So that's why that one's wrong. 2 ensure pancreatic enzymes are taking QID. This is a misnomer. It's a myth in nursing that pancreatic enzymes are taken 4 times a day. They're not taken 4 times a day. They're taken with every meal and snack throughout the day. So every time that someone eats or drinks something or has a snack, they have to take their pancreatic enzymes. Okay, so it's not just with every meal, it's also with every snack and with every single thing that they eat or drink, minus water. They don't have to take it with water. Otherwise, they have to be taking it all the time. And I'm all about linking to other things. Pancreatic enzymes can be linked or can also be used in patients who have pancreatitis, so adult patients who have pancreatitis, whether it's acute or chronic. And you'll also see them take pancreatic enzymes with every meal and with every snack. So don't ever look for an answer that says, well, they should be taking like 1 pill 4 times a day, because there are some patients that take 20, 30, 40 pancreatic enzymes a day or more. Okay. Number 3, which was administer antibiotic as prescribed for respiratory infection only. Okay. As a test taking strategy, anytime you see the word only, every, none, never, always, all those words that are what I call absolutes, and what a lot of board review books say are absolutes, meaning they are completely defining. There's no gray area. It either is or it isn't. Those are generally wrong on the boards. So as a general practice, I tell new grads that if you are stuck between 2 answers and one of them has an absolute in it and the other one doesn't, then get rid of the one with the absolute, because 9 times out of 10, it's going to be wrong. Now, there are exceptions to the rule, just like there are no absolutes. So that's the reason that that one is wrong. And also, patients that have cystic fibrosis take antibiotics, not just for respiratory infections, for any infections, and they don't just take them when they have them. Many times they take them prophylactically in order to prevent the infection. Okay, so that's the theory behind that one. And then the last one, which was the right answer, perform chest physiotherapy on a scheduled basis daily, is the correct answer. People who have cystic fibrosis need to have regularly scheduled chest physiotherapy, whether it's done by a respiratory therapist in a clinical setting, a nurse in a clinical setting, or when they go home by a caregiver, a home health nurse, or a parent, or a significant other if they're adults. It needs to be performed on a scheduled basis daily. Okay, so that's the answer to number 1. Okay, so to sort of talk about those kinds of things, cystic fibrosis is a great example of a COPD. So on the boards, if you get questions about emphysema, cystic fibrosis, or chronic asthma, they generally have the same general assessment and management. So if you know it for one, you know it for all. That's what I call linking. Okay, you can assess the person who has one of them, you can assess all of them. And for this particular health alteration, because it's a respiratory health alteration, a lot of the respiratory assessment that falls under COPD that we perform as nurses also applies to any patient who you need to do a respiratory assessment on. You'd still be looking for those same things. So if someone had pneumonia, if someone was a post-op patient and you were assessing their respiratory system, if someone had bronchitis or bronchiolitis, the respiratory assessment is generally the same for everybody. So if you know it for one patient, you know it for any patient who has a respiratory alteration or is at risk for respiratory alteration. So again, don't think about it as just being respiratory, because if you have a patient who's immobilized, they're at high risk for pneumonia. So their primary problem is their immobilization. The secondary effects of that may be a respiratory alteration, and then you would have that. So if you're only studying from a board review book and you go and you read about emphysema or cystic fibrosis or chronic asthma, you're reading the same information over and over and over again, and that's a waste of your time. So if you know it for one thing, you know it for a lot of things. Okay? By the way, in the emphysema there where it says secondary, when they mention emphysema on the boards, if they don't put primary in front of it, then they're talking about the emphysema that you all think about as a respiratory COPD. primary emphysema is a genetically transmitted disorder that's a deficiency in alpha antitrypsin that they won't ask you on the boards. Okay, so you're not going to have to worry about that. Let's see if I can go backwards. Okay. Okay, so this is a respiratory assessment. Okay, doesn't matter whether I say it's emphysema or whether I say it's chronic asthma, whether I say it's cystic fibrosis or anything else. Okay, if it has a star, it's only for COPD. Otherwise, you can use these for any patient. So in my world of NCLEX preparation, if you can assess a patient, then you can intervene and you can evaluate. So for every assessment that you are looking at, as you're practicing with test questions, you should be thinking, how would I intervene? And then how would I evaluate if my intervention was effective or not? And then how would I modify it if I need to? So that's why I'm saying when you practice, if you take a 60-item test and then you grade it, make sure you go through every option and every rationale, and then be thinking to yourself, what would I have done? How would I do this? So that you're learning from what you already know. You're utilizing it. You're conceptualizing what you've already learned in nursing school. Okay, so when you do a respiratory assessment, look at changes in respiratory rate or pattern. So are they tachypnic? Are they bradypnic? Are they orthopnic? Are they dyspneic? Do they have periods of apnea or shortness of breath? That's the same for anybody. If you have a post-op patient, you're checking for that. Okay, so remember, if on the off chance you were to get a question about a nursing diagnosis, okay, this is ineffective breathing patterns. Okay, ineffective breathing patterns. People want to write on the boards, or people want to choose an answer that's like impaired gas exchange for everything. Okay, impaired gas exchange is only applicable if someone has a change in their arterial blood gases or their oxygenation levels. Okay, this is actually where someone is not breathing appropriately, so that's ineffective breathing patterns. Okay, so you measure this. What do you do? For a lot of these, if you just change their position, then that's how you change it. Okay, and then you reevaluate to see, has the tachypnea gone away, the bradypnea, and so forth and so forth. Sometimes we may need oxygen, and we'll talk about all those as we move forward. Okay, use of accessory muscles. Do they have retractions? Do they have nasal flaring? And do infants head bob? If you've never seen head bobbing and you're looking at me on a camera, when a baby lays in a bassinet or in a crib, if they're having difficulty breathing and their compensatory mechanism is to use their accessory muscles, you'll see that they're actually bobbing their head like this while they're sleeping. Okay, they're not doing it consciously. It's a compensatory mechanism. It's to get them to use the accessory muscles in their neck and in their upper chest so that they get in more oxygen and can blow off more CO2. So you want to note that. Okay, that's the same for everybody. Doesn't change. Do they have excessive mucus? Okay, now this is very specific. The thick, tenacious, and copious is very specific for someone with cystic fibrosis, but all patients who have respiratory disorders can have excessive mucus. And so you need to measure that, okay? Is it thick? Is it sticky, which is tenacious? Is it copious? Is there a lot of it? And then I always say, is there an odor? And respiratory secretions have a very distinct odor, particularly if they're growing certain organisms. So for any drainage, anything that comes out of the body, doesn't matter if it's respiratory, if it's drainage from a dressing, if it's drainage in a particular tube, whatever that drainage is, what's the color, what's the amount, what's the consistency, and what's the odor. Okay, so in a respiratory assessment, you're looking at the mucus. And again, if you have someone with cystic fibrosis, particularly, it's going to be thicker and sticky and in large amounts because they have a disorder of their exocrine glands, which are mucus-producing glands. Okay, so that's something specific about the disorder, but the rest of it can be used for a lot of different things. Okay. Adventitious breath sounds. So do they have rales or ralls and crackles, okay, indicating fluid in their lungs? Do they have bronchi, indicating an airway obstruction? So that airway obstruction can be from something that is causing bronchoconstriction, or it can be from some kind of a foreign object that somebody has swallowed. And then do they have wheezes? Sometimes on the boards, they will use all of these terminology. In practice, make sure that you know what to use for your individual institution, because people define, clinical institutions define these somewhat differently. So that's what you want to be looking for. Think of rhonchi and wheezes as being obstructions, and rales or rales and crackles as being fluid. And remember, this is not just for people that have respiratory conditions. In patients who have renal conditions, if they build up with edema, they can get crackles. Okay? You assess it the same way. It's not any different than if you're assessing a respiratory patient. So that's the linking it. What else can you use it for? Do they have a cough that's non-productive or productive? Again, what are they producing? What's the amount, the color, the consistency, and is there an odor? Pursed lip breathing, that's, sometimes you see pursed lip breathing in any respiratory patients. You do probably see it more in COPD patients, so I should have put a little star there for you. But remember that pursed lip breathing is something you can also teach a patient. And remember, the purpose of it is for them to get in more oxygen, but also to be able to blow out more CO2. Remember that everything in a respiratory condition is to extend or expand expiration, because expiration is where O2 and CO2 exchange takes place. Okay. Do they have periods of cyanosis? Remember, cyanosis and any color changes. So now I'm going to link it to something else. Any color changes, jaundice, paleness, pallor, hyperemia, which is redness, whatever color change you might see, remember, don't generally do what you see often done in practice, which is to look at the nail beds or to look at the back of the hand or somewhere else like that. You want to look in the sclera, the conjunctival sac, the mucous membranes, okay, and around the mouth. Okay, those are where you want to look for color changes. You do not want to be looking for color changes anywhere else. Skin color and all the variations of it do not allow you to accurately assess one's changes in color. So the sclera, the conjunctival sac, the mucous membranes, and for a respiratory condition, it can also be circumoral or around the mouth. Okay. Grunting is something that you hear or you can assess in infants. Again, it's a compensatory mechanism. It's to extend, it's their version of extending expiration so that they can exchange O2 and CO2. So you hear them grunt at the end of respiration. So if they go, that's a grunt. Yes, I actually do. I do animation for you while we're on the webinar. Okay, so that's a COPD. Barrel chestedness, that you primarily see in COPD patients. If you've never seen someone who has emphysema or cystic fibrosis or someone with a other chronic obstructive pulmonary disease, they get very barrel chested. Clubbing of the nail beds, which is a late sign of hypoxia. If you have not seen patients with clubbing of the nail beds, just remember, if you look at their nail beds like this and you're looking at their nail, it's an overarching of their nail bed. They're not going to ask you to measure it. They just want to know if they have it. You're going to see clubbing of the nail beds in both the fingers and in the toes. And then respiratory acidosis, which most, not all, most COPD patients will have. Most COPD patients have some slight respiratory acidosis. And I do remind people that an important strategy to understand on the boards is not to get hung up between the difference between what's normal and what's expected. Okay, we expect that patients who have COPD will have some respiratory acidosis, but it's never normal. So if you get an ABG result back and it shows that the patient has respiratory acidosis, you don't chart normal because they have COPD. They still have respiratory acidosis. And if you're not comfortable with how to do ABGs on the boards, then that's something that you want to practice, because that's a high percentage area in making sure not only that you can do respiratory acidosis and alkalosis and metabolic acidosis and alkalosis by number, but also by narrative. Meaning if someone's having a panic attack, they're at high risk for respiratory alkalosis because they're blowing off CO2. That's why we have them breathe in the brown paper bag so that they're rebreathing their CO2. Just like someone who has diabetic ketoacidosis is at high risk for, obviously, metabolic acidosis. So you want to make sure that you can do those. If you have difficulty with ABGs, and you need help, again, if you're a member, if you're a Sigma member right now, you can post in the career advice forum and I'll pick it up there. Or anybody can email me, member or non-member. You can all email me if you have a question like that. And again, I'll try to help you with that, and I'll put my email or my social media set up at the end, and you can message me that way as well. Okay, so now let's talk a little bit about specifics to cystic fibrosis. So I've already mentioned this, the genetic transmission. So again, if you know it for cystic fibrosis, you also know the genetic transmission for sickle cell anemia. Okay, it's the exact same thing, autosomal recessive. So we've already gone over that. Okay, lack of meconium stool. So if a baby is born and does not have a meconium stool within the first 48 hours, okay, and if you've been on my webinars before, I love the number 2. If you've not been on a call before with me, then the number 2 or some version of 2, like 2 days, is a good measure if you don't understand time frames of things. So a newborn should have a meconium stool in the first 48 hours or 2 days. And if they lack that, then they need to be tested for cystic fibrosis. If they have a history of chronic or repetitive upper respiratory infections, they need to be tested for cystic fibrosis. Okay, so the definitive diagnostic test is the sweat test. Okay, basically they take a little electrode, they put it on their wrist, they heat them up, they make them sweat, and then they measure the amount of sodium chloride in their sweat. If it's greater than 60 milliequivalents, that's a definitive test for cystic fibrosis. That means they have it. If it's between 40 and 60, that's suspect. You retest in 2 to 3 months. And if it's less than 40, they don't have cystic fibrosis. And then they'll actually work them up for a cardiac disorder, for a congenital heart disorder, particularly if they've had a lot of chronic or repetitive upper respiratory infections. And we'll talk about that later on. Okay. Also, they can do scope procedures, bronchoscopes, and things like that in order to diagnose the damage to the lungs as the patient is getting older. They'll have repetitive bronchoscopies done in order to see the damage that's happening to the lungs over time, because the lungs will become less and less compliant the more fibrotic or tissue damage there's done in the lungs. And if you know how to prep someone or assess someone before and after for a bronchoscope, you know how to do it for every scope procedure. So again, that's sort of linking. And remember, anybody who gets a scope procedure needs a consent form. Okay, same for all of them. Okay. Then there are, for cystic fibrosis, now we're going to get away from the respiratory side of it. There's also the gastrointestinal effects of CF. Okay, so remember, the same mucus that's blocking up the airways in the respiratory system that we've talked about, same mucus is blocking the pancreatic ducts. So the pancreatic ducts become occluded by that excessive mucus that's thick and tenacious and copious. And so that does not allow the release of pancreatic enzymes. So they have an absence of pancreatic enzymes, which leads to what we generally call a malabsorption syndrome. So they can't absorb anything. Okay. And so when they have a malabsorption syndrome, they're also malabsorbing fat. So you're going to see patients get steatorrhea, which are fatty, frothy, foul-smelling floaters. Okay, that's the way that I think about it. So fatty, foul-smelling, okay, floaters. Okay, so steatorrhea, they're fatty stools. That's basically what it is. Weight loss, they look really thin. If you've never seen a cystic fibrosis patient, they're really, really thin. They can eat as much as they want, and they generally do not gain any weight. They have an increased appetite. They're hungry all the time, and they crave salt because they're spilling salt onto their skin. Okay. They also have an absence of fat-soluble vitamins, so A, D, E, and K. So you have to know if you're going to be giving them supplements, either through multivitamins or particularly with vitamin K, if you start to see that they have a lot of bleeding issues, if they're getting a lot of ecchymotic areas, black and blue marks, petechiae, any of those things that indicate to you bruising that they have are lacking the ability to clot properly, then you need to give them vitamin K, and sometimes they'll give them vitamin K injections for that. Okay. So that's the same though for anybody who has a malabsorption syndrome. So this could be a patient who has acute pancreatitis, okay, or anybody who is absent of fat-soluble vitamins. Okay. So what do you do for this? So this is where we talked about before. They have to take pancreatic enzymes. It's with every meal, snack, everything except for water. If they drink a milkshake, if they drink Ensure, if they're eating peanut butter and crackers, whatever it is, they need to take their pancreatic enzymes. If you don't know the names of all of them, that's fine. Most of them end in ACE because they're enzymes, and most enzymes end in ACE because they break something down. You can figure out most of them. So even if it was an ACE drug that had nothing to do with cystic fibrosis, again, I'm going to link it to something else. If I told you a patient was taking diabinase, then first of all, the ACE is the enzyme. The diab should have been an indication that it's for diabetes, and that's an oral hypoglycemic. It's breaking down glucose. If I changed it and I said the patient was taking streptokinase or urokinase, okay, those are clot busters. So now the enzyme's breaking down the clot. So the ACE drug breaks down something. And so as a test strategy, if you get a question with a drug that ends in ACE and you have no idea what it is, just think it's breaking down and then look for an option where something's being broken down and take that answer. And you're going to be right generally 85% of the time. And that's what you want because you're going to have made the right choice. Okay. These patients get high protein, high calorie diets. There's no changes in fat. There used to be sort of a rule of thumb that we change the fat in cystic fibrosis diets, but we don't do that anymore. So no changes in fat, no limits on salty foods, okay? High protein, high calorie supplements. We basically let them eat what they want because they're losing weight, they're not absorbing a lot of it. Even when they're taking their pancreatic enzymes, they're not absorbing that much. And so we want to make sure that they are at least getting sound nutrition. And you're going to administer fat-soluble vitamins. And then any patient that you take care of on the boards, okay, where there is any change in nutrition, in hydration status, in weight, make sure you're doing daily weights and strict INOs. One of the things that happens on the boards a lot, particularly with select all that apply questions, but also with multiple choice, is that people will see an answer like daily weight or strict INO, and in your head, you become a lawyer as a test taker and you say, oh, that's just too easy. They must be trying to trick me. There must be another answer. And so you start to argue with the question. The question's not going to argue back with you. And so it's important to remember that if it seems easy, it's generally because you know the answer. It's not because they're putting something easy there just to trick you. Okay? So if you know it, then pick it and go on. Go on. Doesn't want to click for me. There we go. Okay, and then lastly with cystic fibrosis, there are reproductive effects. Males with cystic fibrosis are generally sterile. The mucus occludes the vas deferens, so they can't ejaculate. If they can't ejaculate, then they are in essence sterile. And most females are sterile, but not all, so there's no absolute there. The mucus can occlude the cervix, but it doesn't in all females. So there is a small percentage of females that can get pregnant and carry the pregnancy to term, and then they would have, their baby would have the risk of having cystic fibrosis. But it would be different than the person who just had the trait, okay? So because they're actually carrying the disease, then there's a 50-50 chance that the baby will have the disease or the baby will have the trait. There's generally not a chance that they will be no trait, no disease, okay? It's a general thing to just remember before we go to question 2. Just remember, in the board review books, a lot of times cystic fibrosis will be identified primarily as a pediatric disorder, and it is, but there are adults now living with cystic fibrosis because of the advent of great antibiotic therapy and respiratory therapy. So there are patients that have lived into their 40s and 50s with cystic fibrosis. So every once in a while, in a practice test, you might see the adult with cystic fibrosis, but from the board's perspective, they will still generally be children if you get a question about that. And if there's a question about how long they live, there is generally not on the boards, that type of question, but again, in the practice test that you're taking might be, and most kids who have cystic fibrosis live into their 20s. That's the general range. Okay, so now we're going to do practice question number 2 about epilepsy. Okay, so read it carefully and then choose your answer. Okay. Okay, a nurse is caring for a client who begins a grand mal seizure while in bed. What actions by the nurse would be contraindicated? Okay, well, congratulations to the 89% of you that picked the correct answer, which is you do not restrain the client's limbs to prevent injury. Okay, that's the contraindication. If you miss this question, 9 times out of 10, it's because you missed the word contraindication. So this is an example of a reading question. There are lots of people that miss questions on the boards that have nothing to do with their knowledge or nothing to do with their content and everything to do with their ability to read. Because when you're nervous, you either read really fast or you read really slow and you get confused. So a lot of times you're going to see that the important information or that one word that is going to help you answer it is often at the end to make sure that you're reading all the way across. So in this one, the fact that it says contraindicated, meaning you would not do that, is you do not restrain the client's limbs to prevent injury. And the reason for that is if you restrain them during the tonic-clonic movements that they're having, the muscles are working so hard between the tonus and the clonus that they're going through that if you try to hold it down, you'll actually fracture their bones. And they'll actually have broken bones after the seizure is over. So that's why we have padded side rails. And that's why if they're not in a bed and they're in a chair, you move them to the floor and you make sure that the environment is free of any type of equipment or furniture or anything else in the environment that they might hit. Because again, if they hit something, the tendency is for them to get broken bones. You do turn that client's head to the side if you can. You don't have to move them. They can be seizing and you can still turn the head to the side. And the reason that you do that is, one, you want their tongue to fall out so that they don't get that excessive salivation, which then they can then block their airway, which in layman's terms we call frothing. But in medical terminology, it's excessive salivation. So you do turn their head to the side. Also, if they start to get circumoral cyanosis or they start to get periods of cyanosis, then you can administer oxygen to them if their head is turned to the side by just holding an oxygen mask underneath their nose and mouth so that they're breathing in the oxygen. So 4 was right for that reason. And then you clearly want to loosen restrictive clothing. So y'all did very good on that one. So now we'll talk a little bit about epilepsy. And epilepsy is a high percentage area. You're going to see that there is in the pool of questions. So if there were 4,000 questions in the pool of questions, then everybody minus 10% of you might get a question. But there will be some of you that never get a question. So again, these are things that have the highest percentage of showing up on somebody's boards. So when they ask questions about epilepsy, which sometimes can be called convulsive disorders and sometimes can be called seizure disorders, on the boards, they generally ask one of 2 types, either grand mal seizures, which is the most common seizure that gets asked about on the boards, or petit mal seizures, which will come in a few slides. So remember that grand mal seizures are generalized. That means that the whole brain, that the brain is involved to the point that the patient's going to lose consciousness. Okay, that's the definition of a generalized seizure. So remember, when you're thinking of your assessment, think about the interventions that you will do for each of those, and then later on how you would evaluate them. Adolescents and adults may present with what we call an aura. You will either know that because they've told you before they start to seize, or you can ask them that in a admission history if they're being admitted to work them up for epilepsy, or you can ask them afterwards once they've woken up from sleep after the seizure is over if they had an aura. Okay, so remember, an aura is a premonition, and it indicates what part of the brain or what lobe of the brain is where the seizure started, okay, what we call the epileptogenic focus. So if someone has a parietal focus, then their sensation, they may have a sensory aura. And so there are lots of different things that people present with. Some people smell coffee, some people smell alcohol preps, some people hear train whistles. There are lots of different auras, but the aura is very specific to the individual patient and to where the seizure is emanating from or starting from. And so from a nursing perspective, it's very important that you get that information, because that helps the physician then look on a CAT scan or an MRI or a PET scan to determine where the seizure may be starting from. And that gives them sort of the map or the guide of where to look. Children do not get auras. Okay, children do not get auras. You have to have a well-defined and well-established central nervous system, which kids generally, their brain is still growing, so they don't have. So is there an exception to the rule? Yes. In practice, if you work on a neuro floor like I did when I was practicing, yes, every once in a while you'll see a kid with an aura. But in most cases, we define that as an adolescent or somebody over the age of 12 through adulthood. Okay. So we've already said loss of consciousness, tonic-clonic movements. So there's the risk for injury. You need to protect the patient. The number one priority goal for these patients is safety. Safety, safety, safety. Protect the patient. So when they are having tonic-clonic movements, they need to be prevented from hitting anything. They're going to have pupil deviation. So the seizure starts on the side opposite of the deviation. So if their eyes deviate to the right, then the seizure is starting on the left. If their eyes deviate to the left, then it started on the right. And in some cases, if both eyes are either back or staring straight forward, that actually indicates to the physician, when you tell them that they have two foci, meaning that there are two parts of the brain where the seizure is starting from. And that's why they have that particular assessment finding. So again, it's important for the nurse to be able to look at the patient and assess that and then pass that information on so that we know how then to manage it. Okay, clenched jaw, please, please, please. On a select all that apply, if you were to get one about this, and these are assessments are good select all that apply questions because you can get 6 answers in there and people have to choose from them. Do not put anything in the patient's mouth. Okay, that includes padded tongue blades, which most of you know about, but I mean anything. Okay, they'll put things sometimes in a question, we'll put, a towel or put something else. They all seem funny when you're thinking about them now, but when you're nervous and you're taking the board, sometimes your brain plays tricks on you. Don't put anything in their mouth, okay? The reason that we used to use them was to prevent them from the old wives' tale of swallowing their tongue. It is physiologically impossible to swallow your tongue, okay? The object is to turn their head to the side, let the tongue fall out. So again, they don't get that excessive salivation, but don't put anything in their mouth, because once their jaw is clenched, it's not going to unclench until the seizure is over. And so whatever's in their mouth is going to break. So, plastic spoons, they're going to break. Their mouth's going to be all cut up. There have been instances where people have put their hand in their mouth because someone has had a seizure in a mall and they think that they're helping them. And then that person has lost a finger. So you need to not put anything in their mouth. When their jaw clenches, leave it alone. Again, more important even then that their head is turned to the side, because now that excessive salivation needs to come through the clenched jaw. Periods of apnea or cyanosis, again, think oxygenation and airway. Turn the head to the side. Okay. Get oxygen near them if you can, okay, if they have cyanosis. You don't need to put them on. You don't need to put the nasal cannula in. You don't need to put the mask on. you're going to be in there with them. You don't leave a patient alone that's seizing. So just take the face mask and just hold it underneath them, and they'll be breathing the oxygen in, and that's fine. Excessive salivation, again, we talked about that. That's a high risk for aspiration. That's anybody that has excessive salivation. Doesn't matter if they have epilepsy. Anybody with excessive salivation, we can go back to the respiratory patient. Okay, that has excessive salivation, they're at risk for aspiration as too. So turn their head to the side. Okay. Usually most seizures do not last more than 2 minutes. So there's another 2. Okay. Another 2 minutes. That's it. If someone has the end of a seizure and the next one starts, that's when they have what's called status epilepticus. Okay. And we'll talk about that in a minute. Okay, post-seizure. So now the seizure's over. What's going to happen? Generally, the patient will tell you they don't remember what happened. So they have memory loss. Okay, that's from the effects of the central nervous system as they've had loss of consciousness and the brain has been seizing. They will usually be incontinent of both urine and feces. Okay, so that's an issue that you want to make sure that as the nurse that we're managing, and they're generally very tired. So we generally let them sleep. And then after they wake up is when you can ask them questions about anything that they might remember, or if they did have an aura, and then you can go ahead and you can document that. But that's what you're looking at. So when you're talking about what we just assessed, again, safety, protect their airway and oxygenation, monitor them closely post-seizure, because again, you want to make sure that they do not develop a seizure right after the other. Again, that's called status epilepticus. That is a medical emergency. Okay, a medical emergency. If they have status epilepticus, I'm skipping a couple of points, but if they have status epilepticus, then you want to administer lorazepam or some similar drug. The lorazepam is Ativan, and it can be given IV, and it is a central nervous system depressant, as are most PAM drugs, and that will help to depress the central nervous system so that the excitability of the brain diminishes, so the seizure will start to abate. Okay, if you don't have an order for lorazepam because nobody knew that the patient had the propensity for status epilepticus, this is an example of when you can call the doctor. And I'm not a big advocate of people calling the doctor on the boards, but you can call the doctor for a medical emergency, or if you have all the information that the physician is going to ask you, you have already got it, and they've told you that in your scenario. If there's something that the physician would ask you that you don't have the information for, and that's an option, do that first. Don't jump to call the doctor. Okay, this is not a physician's exam. This is a registered nursing exam. Most of the answers are going to be about what we do. Okay, but things that have emergencies attached to them, and you have whatever the physician would ask you, then you can call the doctor. Okay, so status is one of those emergent words, like status asthmaticus would be another medical emergency. Okay, in general, there are hundreds of anticonvulsants that are on the market today. If you get a question about an anticonvulsant on the boards, usually the 2 most common asked about are phenytoin, which is Dilantin, and phenobarbital, which is Luminol. Okay, Dilantin, probably the #1 question asked on both practice tests, and if you were to get it on the boards, has to do with the side effect of Dilantin, which is gingival hyperplasia, which again, if you get to the boards and you don't know what something is, try to break the words apart. So hyper means overgrowth, plasia means tissue, gingival means mouth or gums. So it's an overgrowth of tissue of the gums. Break the words down. Again, if you go back to what I said on the very first slide, this is why you want those strategies to be ingrained in you when you practice for the boards. So that if you see something on a practice test and you don't know it, don't say, I'll go back and look it up later. Look it up right then if you can't break the word down, so that it's part of your studying, and then it becomes part of the way you answer test questions. Okay, so that's probably the #1 question, is about the gingival hyperplasia, and then the nursing intervention is effective mouth care or effective oral care. Excuse me, making sure that you're keeping the mouth clean, and that you teach the parents and or the patient to keep their mouth clean and make sure they go to the dentist on a regular basis. Okay, phenobarbital is a barbiturate. Most drugs that have barb in them someplace are barbiturates. and barbiturates are central nervous system depressants. And so again, for obvious reasons, if you depress the central nervous system, the patient will not be seizing as much. Okay. Remember that when you give phenobarbital to patients, particularly because it is a central nervous system depressant, then if it's only ordered daily, then give it at night, okay, or at sleep, because you want their central nervous system to be depressed more when they are sleeping, because one of the side effects is lethargy. And that's why you always see as a nursing intervention to make sure that you teach them not to be driving cars. You know, on the pharmacy bottle, it usually says heavy machinery, but they're not going to talk about it. But you want them to know that it is going to make them lethargic or sleepy. Okay. All the other drugs that are out there that are used for anticonvulsants, you may see in a board review book, and you may see in a board review practice test, or if you're using some of the online practice companies' test questions. But from a board's perspective, those are the two most common that are going to be asked about. Okay, because it's the two drugs that most people are exposed to. And remember, just from a board's perspective, every question that the computer picks from the pool of questions, every student who graduated from every school in the United States of America has to be able to have had that information. That's what minimal competency is. And it has to be basically the same information that everybody would have learned in school. Okay, it's not going to be the latest and the greatest drug. Okay, it's not going to be something that only people who work in big urban centers and academic centers will have seen, and no one else will have seen. Okay, so it's important to remember that. Also, when you're talking about epilepsy, if the question is attached to a child, don't forget about growth and development and psychosocial issues related to chronic disease. And those same things can also be asked in adults. So remember that if you don't understand Erickson's 8 stages of development, you should at least know what they are, okay, and how you could evaluate, you know, trust versus mistrust, or how you could evaluate intimacy versus isolation, or so forth and so on. That's a good way for them to get a growth and developmental question in without it seeming like a growth and development question. They'll attach it to a disease entity rather than just asking, you know, what can a 3-year-old do? Okay. So you need to think about those things as well. Okay, and the other kinds of seizures that they might ask about are petit mal seizures, which are also called absence seizures, or absence if you like it that way, which are also generalized seizures. Okay, these are primarily found in kids. They're usually outgrown. They are not precursors to grand mal seizures. So if you get a question about a petit mal seizure on a practice test or on the boards, and, you know, one of the options is, well, if they have petit mal seizures, then you need to teach them that they're going to get grand mal seizures later on in life. No, they have nothing to do with each other. They're usually outgrown, but they are generalized. Okay, so it's the same generalization that's occurring across the brain in someone who has a petit mal seizure as someone who has a grand mal seizure. And you know that because they lose consciousness. The difference is, in a grand mal seizure, they have the tonic-clonic movements. Okay? And in a generalized petit mal seizure, their loss of consciousness is identified by them having a blank stare or staring into space, or, you know, sometimes you'll get a question that says the teacher calls a parent and says that the child is being very inattentive. That's what they're doing. So they're just staring straight into space. So if you're looking at me on the camera right now and I'm just staring straight into space, and you look at them, all they're going to be doing is just blinking their eyelids like this. You can go back and do this, and they're not moving. Okay, they don't move. Okay, that's because they're unconscious, but they're not going to drop to the floor. They're not going to need to be moved to the floor. They just are in wherever they are. That's what they're doing. That blank stare, or staring into space, or that inattentiveness. And they generally will have rapid blinking eye movements. And again, the school teacher generally will say they're not attentive in class. These also last about less than 2 minutes, and then the child will go back to doing exactly what they were doing, okay, as if nothing ever happened. So you do want to protect them from injury. You want to make sure that there's nothing in the environment that could hurt them. But if they're in a chair, you know, and you're right there, they're not going to fall on the ground as a general rule. So just make sure that you're protecting them from the general environment. Administer anticonvulsants. Usually they take phenobarb for this. Educate school personnel, And then again, the growth and development issues. One of the things about people that have chronic disorders on the boards is when you have a chronic disorder as a child, you want to make sure that the parents understand that you don't want them to be overprotective. You want kids to have normal growth and development within the confines of whatever that chronic disease is. You don't want them to become sheltered, and you don't want them not to be able to participate in the normal activities that kids participate in, as long as it's within the guidelines of managing their particular disorder. And again, most of these kids outgrow this, so that's a good thing. Okay, practice question number 3. This is going to be the last one where you're actually doing the poll. So Megan will be nice and put it up for me. There we go. Okay, so this one is about nephrotic syndrome. There we go. Okay, so a nurse completes an admission assessment for a child diagnosed with nephrotic syndrome. The most common assessment associated with the nephrotic syndrome, we ran out of characters, don't worry, will be, so we've got hypertension, generalized edema, bright red hematuria, and hyperalbuminemia. Okay, so this, just from my standpoint, from a statistical standpoint, this is an example of a good question because every option got picked and there was a good spread. The correct answer, for those of you that answered generalized edema, that is the correct answer, and you can give yourself a pat on the back for knowing that. Those of you that missed it, I will explain why. Okay, so in nephrotic syndrome, while hypertension is an assessment that you will find in renal disorders, in most renal disorders, one of the distinctions between acute glomerulonephritis, which we'll talk about next, and nephrotic syndrome is the hypertension. Hypertension is generally found in patients who have AGN or acute glomerulonephritis. Most kids that have nephrotic syndrome have what's called minimal change or no change nephrotic syndrome, meaning that the blood pressure is not reflective of their renal dysfunction. So most kids with nephrotic syndrome don't have hypertension. Okay, that doesn't mean that later on, as they get closer to end-stage renal disease, that they won't develop it. But as a common assessment, you generally do not see that. So if you were to get a select all that apply that made a distinction between acute glomerulonephritis and nephrotic syndrome, acute glomerulonephritis would be more hypertensive than the person with nephrotic syndrome, even though intrinsically in your head, you're thinking, well, nephrotic syndrome is chronic and acute glomerulonephritis is acute. You would think it would be the other way, but it's not. Okay, so hypertension is not primarily seen in nephrotic syndrome. Okay, I'll skip edema for a minute. Bright red hematuria, there will be hematuria because in patients with nephrotic syndrome, just like with acute glomerulonephritis, there is a tear or a injury to the glomerular basement membrane, and that's the covering, like the blood-brain barrier of the brain. This is the covering, the glomerular basement membrane of the nephron, and it allows the release of protein and also the release of red blood cells. And so you do get hematuria, but it's not bright red. They're not hemorrhaging. So you get what's called tea-colored urine. Okay, so it sort of looks brown. Okay, it doesn't look bright red. So there will be hematuria, but it'll be tea-colored, okay, like if you made hot tea, rather than the bright red. Hyperbilirubinemia is the opposite. Patients who have nephrotic syndrome, because they are losing protein in their urine, so they're going to have proteinuria, Okay, and that's the same proteinuria, same kinds of things you'll see with them as you would if someone who had pregnancy-induced hypertension or any other kind of renal condition where they had spillage of protein. If you spill protein in your urine, you have less protein in your blood. So they would have hypoalbuminemia or hypoproteinemia. Usually from a clinical perspective, we use the word protein when it's in the urine and we use albumin when it's in the serum. So they would have hypoalbuminemia. So the most common, and that was the key there, the most common is generalized edema. And that is a common assessment finding in nephrotic syndrome. You will see edema in patients with acute glomerulonephritis as well, but generalized edema, often dependent edema, is what you see in patients who have nephrotic syndrome. And when you get generalized edema, sometimes that's called anasarca, which is generalized edema of the body. Okay, and we'll talk about that. Okay, and again, if you're missing some of these questions, that's what practice is for. Okay, that's what practice is for. It's not to make you feel bad. It's to make you feel, I need to keep practicing, and that's it. No big deal. Okay, so just like a lot of other things in practice and studying for the boards, I like studying things that are either opposite each other or connected together. So if you know hyperthyroidism, you know hypo. If you know diabetes insipidus, you should know syndrome of inappropriate ADH. If you know Cushing's syndrome, you should know Addison's. Angina and MI should get studied together. So in the renal system, acute glomerulonephritis and nephrotic syndrome, I put together because they have a lot of similarities. Again, both of them are disorders that occur secondary to, again, an injury to the glomerular basement membrane. So they have a lot of similar assessment findings. One of the main differences between them is that in acute glomerulonephritis, it follows a strep infection, generally speaking. So generally 10 to 14 days after a strep infection, then they develop acute glomerulonephritis. So if you get a question about this, then in the history, don't just ask them, have you had a strep test done? Okay, because lots of people who have strep don't ever get a strep test done. You want to ask them, have they had a recent sore throat? Or the parents, have they had a recent sore throat? Or even a GI infection, because strep can also occur in the gastrointestinal system. If you want to know from a diagnostic standpoint, if someone has had strep in their system, they can do a test called an ASO titer, which stands for anti-strep, and that's a titer that you can do. And if it's elevated, they've had strep in their system. Okay, so it's a quick test that they can do. That's an acute condition, and it'll abate. Usually people who have acute glomerulonephritis, it does not come back. It was directly linked to that infection. That's similar, if you want to link it to something else, that's similar to the respiratory infections or GI infections that you may get with people who have Guillain-Barré as a neuromuscular disorder. So a lot of times patients who have Guillain-Barré have had some type of viral infection prior to them having that particular disorder. So again, looking at similarities of things. Nephrosis, which is the other name for nephrotic syndrome, it's the same thing, okay, is minimal change. That's the blood pressure part of it. It usually develops secondary to another condition, so lupus, diabetes mellitus, and again, on the boards, diabetes will be written out as either diabetes mellitus or diabetes insipidus, okay? There's not a lot of abbreviations on the board, so don't get too hung up on them. They'll write everything out. Nephrosis or nephrotic syndrome is a chronic condition, so it's going to have periods of exacerbations and periods of remission, and these are the patients that are at risk for renal failure, end-stage renal disease, and may need a kidney transplant at some point. So again, as you're thinking of all of those things, what should I be doing? What's the intervention? How do I evaluate? Okay. So for both of these, you need to assess them. So both of these cases, they're going to have oliguria, okay, or some change in urine output. Hematuria, we just talked about. Proteinuria, we just talked about. And again, same kinds of things that you would do for anybody who has proteinuria and hematuria. Make sure you're dipsticking the urine. If they have hematuria and it's consistent, make sure that you're getting at some point to CBC, make sure that they're not getting anemia. Okay. Proteinuria, remember that the more protein somebody loses, the more edematous they get. Okay. The more edematous they get. Protein's job in the body, or albumin's job in the body is to maintain fluid in the vessels, not in the tissues. So if someone has proteinuria, they third space if you're talking about a burn patient. If you're talking about a patient who has pregnancy-induced hypertension, they get generalized edema. In a renal patient, they get generalized edema. So what do we do for that? So anybody with edema, you're going to look, is it dependent? Is it pitting? If it is dependent, where is it? If it's pitting, how much? Okay. Most things that are scaled where you're measuring something are usually on a scale of 1 to 4, +1 to +4. So as a general rule, if you don't know something, if you just think of 2 as being either normal, or if you're measuring pitting, then the higher the number, the worse it is. Okay. So what kinds of things do we do for those patients? So if I change the proteinuria to a burn patient and gave them third spacing, then we would need to give them albumin infusions because you want the fluid to go back into the vessels. So it's similar. You know it. You've learned it. Why are you learning it 100 more times? Just let your brain and your psyche calm down enough to utilize all the information you've learned in school. It's not about relearning it all now. Okay. Anytime you have a patient with edema, for whatever reason, think skincare, because the more edematous the patient, the greater risk there is of skin breakdown, the greater risk there is of pressure ulcers or decubitus ulcers. So again, for every assessment, what do you do? What are you preventing? What can be the complications? How do you do that? Okay. Later on, in patients who have renal disorders, a lot of times they'll get crackles. I mentioned that when we were doing respiratory. And then hypertension, usually found in acute glomerular nephritis, and a late assessment of nephrosis. Okay, I'm trying to watch the clock. So I'm going to get through this, and then I'm going to skip to some other things, and then I'll tell you what we're going to do. Okay. Nursing interventions, obviously, vital signs, especially blood pressure, bed rest, daily weights, strict INO, urine dipstick, fluid restrictions as applicable. If you don't know how to do fluid restrictions just as a general rule, remember that you give the most amount of, if you divide fluids up amongst 3 shifts, well, if we're doing 3 8-hour shifts, they get the most fluids during the day shift when they're awake. They get the next, so usually 2/3 of the fluid is given in the day, and then 1/3 can be given at in the middle or at the evening shift, and then 1/3 at night is generally how you do it. Okay, high protein, low salt diets. Remember, you're going to be replacing the protein, but you also don't want to give them high salt because the salt is going to make them more edematous. And then albumin IV. And if you don't remember this and you have not been on a call with me before, albumin is considered a blood product, which means it needs to be given by an RN, not a nurse, because an LPN is a nurse. So an RN, a registered nurse. Okay, and then again, effective skincare, positioning, growth and development issues for kids. And then remember that antibiotics are only given for patients that have, and that is not that's an exception to the rule with an absolute. Antibiotics are given for acute glomerular nephritis patients, not for nephrotic patients, unless the nephrotic patient has an infection that's different or has nothing necessarily to do with the nephrosis. Okay, I'm going to skip through some of these for a minute. Now, I'll tell you what we're going to do with them, but okay. Now, okay, before you read this question, we usually say 15 minutes for questions. Okay, I'm going to go through some of these in this last 15 minutes. These are just practice questions, and I'm going to explain them to you. Okay, because I want to give you some extra practice. All the other slides that are on here that have content associated with them or where you can link something, those are all going to be posted for you. So you'll be able to access them in the repository. And again, if you're a member and you're used to getting it on the Career Advice Forum, you can get it there, or all of you can get it in the repository. Okay. If you have questions about it, you can ask me about them. If you like the way that this was done, and you want more of things like this or more practice with questions or things like that, when you fill out your evals, let us know that. I'm glad to do as many of these as I can for all of you, as long as Sigma is willing for us to do them, and I know they are. So that's important, and I'll remind you of that at the very end. And if we go over and you can stay on the call, that's fine too. My time is yours. This question, erythromycin has been prescribed for a client with otitis media. I cannot read the rest of my question because of that. The nurse instructs the client how to take this medication. So how do you take it? Okay. On an empty stomach, how do you take erythromycin? On an empty stomach, immediately after a meal, just before eating, or with a snack like peanut butter and crackers. Okay. So that's a practice question. This is actually from a test I give to students to see if they're ready to take the boards. So I apologize if you can hear the lawn guy in my front. I'm in my garage and he's just blowing off the rest of the grass. We'll be on in a moment. Erythromycin, how do you give it? Okay, so of those 4 answers, the correct one is, if you answered on an empty stomach, you would be correct. Now, the theoretical reason for that is because erythromycin is an exception to the rule antibiotic. Most antibiotics can be taken with food. Erythromycin, in order to get the best absorption, needs to be taken on an empty stomach. So it's one of those drugs that if there's an exception about something, that's the thing that you want to keep in the back of your head. If there's one assessment that if I say this, you know it's this, then you know it. That's what they're going to ask you because it's so unique. So for example, if I asked you a question about intussusception, you should say current jelly stools, because the #1 assessment finding of someone with intussusception, which is an involution of one's intestine in a child, is current jelly stools. So you know that. Okay. So in this one, erythromycin is one of those drugs that's an exception to the rule. But if you did not know that, how can you still get it right? Look at all the other options, and that's why you practice with this. So on an empty stomach, skip that one now. So immediately after a meal, just before eating, or with a snack like peanut butter and crackers. All 3 of those are associated with a meal. So if they're all associated with a meal, then they all can't be right. You eliminate all of them and you're left with on an empty stomach and you'd get it right. You have to give yourself permission to choose an answer when you're not sure because you know that the other 3 are wrong. So process of elimination actually shows that you know more information than you think you do because you know the others are wrong. Does the computer care if you know why it needs to be given on an empty stomach? No, the computer does not care. The computer only cares that you pick that as the right answer. So that's an example of that. Here, let's see. A nurse administers a fatal dose of morphine, I'm going to read them off my sheet, of morphine sulfate to a client. During the subsequent investigation of the error, it is determined that the nurse did not assess the client's respiratory rate before administering the medication. Failure to adequately assess the client is addressed under which function of the Nurse Practice Act? I always throw this in there because people always think that there may not be anything about nursing practice and the legal responsibilities of that, but there can be. So this would be a common question. This is one I wrote, but this would be a common question. So if someone fails to check the respiratory rate in someone and then gives them a fatal dose of morphine sulfate, what part of the Nurse Practice Act does that fall under? So defining the specific educational requirements for licensure, describing the scope of practice of licensed and unlicensed care providers, recommending specific terms of incarceration for nurses who violate the law, and identifying the process for disciplinary action if the standards of care are not met. Okay. So the right answer is 4, but most people pick 2. Okay, the right answer is 4 because our scope of practice says that when a registered nurse gives a medication like morphine, it is our responsibility because it is a respiratory depressant to make sure that we assess their respiratory rate prior to giving it so that if it's less than 12, we do not administer the medication. So the standard of care was not met so it falls under that and the disciplinary action that goes with that. If you pick 2, which is the most common answer picked for this question when I use this test, then you read describing the scope of practice of a licensed, and then you just went and you just pushed enter because it said licensed and you said, oh, well, it's telling me about scope of practice of an RN. Yeah, but it doesn't have anything to do with unlicensed personnel. So again, you didn't finish reading it and you make the mistake. So you need to learn to read all 4 options, up and down, and all 4 options, or if it's a select all that apply, all 6 options all the way across. Okay, how about this one? The nursing note that best explains the client's reaction to the medication given during an acute anginal episode would include: 1, after nitroglycerin was taken orally, pain was relieved for about 30 minutes. 2, 2% nitro paste 2 inches long applied to the client's left arm brought relief for 6 hours. 3, after propranolol or Inderal was taken orally, the client's wheezing was quieter and their blood pressure was lower. 4, experienced facial flushing, but pain relief from sublingual nitroglycerin lasted about 45 minutes to an hour. Okay, so this question is about what to do if you're the nurse and someone who has an acute anginal episode or angina. Okay, you don't want to get hung up on it being written like a nursing note. The nursing note part of it there is just to give you information to make you read it as if you were writing it. But it's not asking you to evaluate the nursing note. It's asking you to evaluate what you would expect to see in a patient who has an acute anginal episode if you gave them the particular medication you should. So most people that take this question answer 1, because if you're reading fast, you see nitro and you say that's the answer, because nitro is the thing, the medication we give for acute angina, and that's absolutely right. But we don't give angina orally. Excuse me, nitro orally. We give nitro sublingually. So if you don't read it carefully, you miss that, not because you didn't know the right answer, but because you read it too fast and you saw nitro. Okay, so it's wrong because it's got the word oral in there. 2% nitro paste 2 inches long applied to the client's left arm brought relief for 6 hours. That's actually a good answer if the patient had chronic angina. Okay, so that's not for acute angina, it's for chronic angina. Even if you didn't know that, what would have been the clue? The relief is for 6 hours. Okay, that's long. That's more chronic than it is acute. So you'd get rid of that one. 3, after propranolol or Inderal was taken orally, the client's wheezing was quieter and their blood pressure was lower. Well, that may all be true because an OLOL drug like propranolol is a beta blocker, but we generally, and you can use them, but we generally do not give beta blockers as the primary drug for someone who has acute angina. So that one's out. So 4, experienced facial flushing, but pain relief from sublingual nitroglycerin lasted about 45 minutes to an hour. That's the correct answer. Okay, yes, they get facial flushing. Why? Because nitro is a vasodilator. Pain relief comes from sublingual, and it generally lasts 45 minutes to an hour. If you don't read all the way down and all the options across, you're going to make a mistake. And the most important thing when you go to take the boards is that you're a good test taker. Okay, I could ask you a question standing or sitting with you or on a Zoom call with you and ask you to tell me everything about angina, and you can tell me everything there is to know about angina and how to manage it, and that does not mean you can answer a test question. So this is not just how much content you know. This is not about being the smartest person in school or knowing the most theory or being the best clinician. This is also about, all those things are important, but this is also about being a good test taker, a solid test taker. Okay. A 22-year-old female client incurs facial and nasal injuries in a car accident. She asked the nurse if preparation for nasal surgery is extensive and if it will improve her looks. The statement by the nurse that provides the best preparation for a rhinoplasty would be: 1, you'll receive instructions on the need for nasal packing, as well as a review of mouth breathing techniques. 2, you'll be photographed on your initial visit so that afterwards you can visually see the improvement to your nose. 3, thorough facial cleaning with antibacterial soap and avoidance of face cream should diminish postoperative bacterial flora. And 4, preparation for the surgery includes pain meds such as NSAIDs to build up your pain tolerance and antibiotics to prevent infection. Again, so I'm reading them fast. If you were practicing, you'd be reading them much slower. Okay, so the right answer is the first one. They'll receive instructions on the need for nasal packing as well as a review of mouth breathing techniques, because the question is asking specifically, what is the best prep for a rhinoplasty? It's not asking what is the best information to provide for her psychosocial needs, which would be number 2, where you're photographed and you can see if your nose looks better. That's a psychosocial question and response. This question is asking what's the best for the rhinoplasty. That's number 1. 3 is wrong because you don't use antibacterial soap and thorough facial cleaning. Preps are done in the OR. So we would not be doing that. And 4 is wrong because it has NSAIDs in it, and we don't give anything that will cause bleeding prior to surgery. And that's the same for every patient having surgery. Doesn't matter what they're having, doesn't matter how minimal it is or how major it is. 7 days generally prior to one having surgery, they need to come off any medications like nonsteroidals or anything else that might increase their tendency to bleed. So glaucoma patients, patients having ovarian cysts removed, patients having any kind of surgical procedure anywhere in the body, make sure that you remember that. Okay, okay, let's do one more. All right. I'll skip that one. Okay. A nurse is caring for a client with who's had an allogenic liver transplant and is receiving Prograf. The nurse monitors the client for which adverse effect of the medication. 1, hypotension, 2, profuse diaphoresis, 3, decreased urine output, 4, decreased serum creatinine. Okay, so a nurse is caring for a client with an allogenic liver transplant and they're taking Prograf. The nurse monitors the client for which adverse effect of the medication. Now, if you have been on any webinar with me up to this point, you should have gotten the right answer because I explained to you how to answer adverse effects. If you have not been on a call with me, I'm going to tell you right now how to do this. Okay, so this is the #1 test strategy that people ask me about all the time and tell me helps them answer more boards questions right than they ever thought possible because they practiced with it so much. Okay, so this is how it goes. If you get a question about an adverse effect, okay, and any strategy that I teach you that's mine, these are all my copyrighted strategies, I have tested them over and over and over again. They work 85% of the time or more, which means you'll get them right if you do this. Okay, now the other 15%, yes, may be an exception to the rule, but you will get these right 85% of the time or more if you use these. Okay, so what do you do with an adverse effect? When you get a question with an adverse effect, you want to choose the option that is the worst of the assessments or findings that are there. Okay, the worst one, no matter what the drug, no matter what the patient's health alteration, pick the worst one there, and 85% of that time, it will be renal. And the reason for that theoretically is, and the reason this works, is because many, many drugs have nephrotoxicity as an adverse effect. So when you were in school, of course, everybody honed in on nephrotoxicity when it came to myosin antibiotics. Okay, so myosin antibiotics, they have nephrotoxicity. But there are a lot of drugs that have nephrotoxicity, and autoimmune drugs are one of those classifications. So the right answer is decreased urine output for that reason. Now, if there's no urine answer there, then pick the one that is, again, the worst finding that is presented to you and choose that because it's a best educated guess then. But if there is a urine answer there and you don't know, meaning there's an exception to the rule, okay, and you just don't know what it is, then pick that. Now, when would it not work like that? For example, if you got a question about a toxic or an adverse effect of aspirin, that's tinnitus. Okay, even if I put a urine output question answer there, that's not going to be right. But most people know that tinnitus is the adverse effect of aspirin. So if you know it, don't use the strategy. But if you don't know it, then use the strategy to help you. Okay, hypotension would be wrong. It's not. Okay, autoimmune drugs do not generally give hypotension. Profuse diaphoresis is generally a side effect. And even if it wasn't, it doesn't usually come with autoimmune drugs. And decreased serum creatinine, it would be increased, okay, from the nephrotoxicity. Okay. Okay, so the next slide. That's how you find me. Okay. Now, and I want to mention a couple of things, and then if you still have questions and you want to hang on, I'm glad to answer them. Okay. If you are a Sigma member right now, then you can find me on the circle. So if you're a Sigma member, you know how to get on the circle. Okay. Just go on the circle and just look up my name and you will find me. And you can contact me that way if you would like to do that. If you are not a Sigma member, then you can use these other ways that I'll talk about in a minute. But I do want to encourage you that if you are not a Sigma member, become a Sigma member, okay? Because a lot of the things that you get, like as a member benefit, were some of these earlier webinars that I may repeat now for everybody. That now that we're opening it up to everybody, but there are things that you can only get as a member. There are so many things that you can only get as a member, and I don't want it to be a commercial, so I won't. But I'm a big proponent of becoming a member of Sigma. I've been a member for 40 years. It's the greatest thing that I've ever done. I get more out of it than I ever thought possible. And if you were not inducted with your class, you can still become a member as what's called a nurse leader. So if you go on the website, just go on sigmanursing.org and then go to membership and then look for applying for membership as a nurse leader. There'll be a whole application process that you can go through. And I think that's really important, not just so that you get these kinds of things, because we'll be offering these for everybody now free, but it's something that where there are lots of benefits besides just NCLEX reviews that you won't need after you're licensed anymore. If you want to contact me in another way, my email is lsm4556@aol.com. If you want to follow me on Twitter or Facebook, I usually post NCLEX words of the day. I haven't been posting them every day for the last couple of weeks because I've just been swamped with other work, but I'll go back to posting them this week. They're the same on both pages. So on Twitter, it's at NCLEX-Prof and NCLEX is capped. On Facebook, it's Lois Marshall. And just look for, there's a picture of my Yorkshire Terrier, and he's laying on a nursing career book. So you'll find me there. And if you like Instagram, it's also at NCLEX-Prof. I generally do not post my words of the day there, but if enough of you ask me to do it, I will. If you want to message me on Twitter or Facebook or Instagram because you like that better, that's fine. You can message me there and I'll generally ask you to either send me your email or I'll answer your question directly through the message system that they're using. That's fine. I don't care how you contact me. I don't care what you ask me. You can ask me anything you want. I'm glad to do this for you. I don't want you to worry. There's no cost for anything now, and there's no cost if you contact me afterwards. So everything that I'm doing relative to NCLEX for right now is all free to anybody. So if you want to see more of these through Sigma, then let them know that either through the evaluation or send me an email and let me know that, and I will pass it on to them. You can also let your friends know if they are still studying, particularly because the test dates are going to be much farther out than what we expected because there's social distancing in all the board review sites. So some of you may not get dates right away. So we can do these as long as you need them done. So just ask. And again, if you have individual needs that you want to ask me about, I'm glad to share them with you as well. So all this information will be in the repository. And now, if you have questions and you want to stay on a little longer, Megan can help me entertain questions. And I thank you for your attention with all of this.
Dr. Marshall, I do have a few questions.
Okay.
For select all that apply questions, do you have any tips for tackling these types of questions?
Yeah. Okay. So I was actually going to do that in hopes that we had another one, but I'm going to do it right now for you because you asked. So select all that apply questions to me are actually easier than multiple choice. You all get stuck in your head that it's harder because you have to be able to pick all of the ones that are correct. But if you think about a select all that apply question in the broadest sense of the question, when you answer a multiple choice question, it's just one answer. But in a select all that apply, think out of the box. So for example, if you got a question about the assessment findings in someone who had systematic lupus, okay? If I asked a multiple choice question, most of you would look for a butterfly rash because that's what you all think of as the assessment finding with someone who has lupus. But if I asked you, and that would be right. But if I asked you a question that was a select all that apply, think about not just lupus, but think about lupus as an autoimmune disorder. So they would have a fever. That's one of the answers that generally does not get picked if I gave a select all that apply practice, because people think, oh, fever, everybody has a fever. No, a fever is the reaction to an autoimmune response. So you would get a fever. What happens when you get the butterfly rash? You get dry, scaly, itchy skin. So you may be looking for that. What are the complications that you might see? Maybe there's changes in their renal system because of the renal implications of lupus. So when you answer a select all that apply, think out of the box and broad. What are you looking for as an assessment? What kinds of interventions can you do? And then what would you do with that same assessment and same interventions if you had a complication of that disorder? Is that there? Or is there a complication or something that you would do if you had an extension of the generally primary assessment findings that you would? And if you do them that way, you'll generally get more of them right. Also, as a general rule on select all that apply, none of them is not going to be the answer. You have to pick something, okay? Most of the time, it's not going to just be one of them. There are exceptions to the rule where just one answer will be right, but most of the time it's not one of them. And most of the time, it's not all of them. Now, there are some reviews, and there are also some places that on the National Council of State Boards of Nursing that says that all of the above can be right, and it can be, but it's an exception to the rule. The chances are more likely that it won't be all of them. So read all of the options. There's usually 6 of them, but there could be 5, and make sure that you go through each one and think about it that way. Is it relative to the health alteration they're asking me about? Is it relative to a complication? Is it relative to the classification or the system that it's in? And that will help you answer them better. And if we do another one of these, I'll give some practice with select all that apply.
You had mentioned reading ABGs. How do you tell if someone is compensating or if they're uncompensated?
Okay, that's a good question. Okay, so on the boards, compensation generally works like this, okay? Compensation is for the body, okay? So the body compensates. So if the way that I teach people to do this is, and I'm going to say it for you, so I'll say it slowly. If you have someone who has a pH of 7.29, I'm going to write it down so I don't forget what I'm telling you, 7.29, and they have a PCO2 of 52, and they have an HCO3 of 30, okay, so if you're writing this down, pH 7.29, PCO2 of 52, and HCO3 of 30, so bicarb. Okay, the way that you do this is look at the pH first. Is it acidotic or alkalotic? So this is acidotic. Okay. Then go to the next one, so PCO2. So normal is 35 to 45, so this is acidotic. And then bicarb is 22 to 26, so this is 30, so this is alkalotic. Whatever matches the pH is the primary problem. So this is primary, so this is respiratory acidosis with metabolic compensation. Okay, and that's how you do it. If I change the HCO3 to 24, then that would be respiratory acidosis with no compensation, because the body hasn't compensated yet because the HCO3 is normal. So whatever matches the pH is the primary problem. If the other one is abnormal in the opposite direction, that's the compensation. And if it's normal, then there's no compensation. On the boards, not only will they ask you about that, but they'll also ask you about correction. So compensation is what the body does, and correction is what we do as healthcare providers. So if someone is acidotic and we give them sodium bicarb, then we're correcting them. If someone has respiratory acidosis and we change the settings on their ventilator, then we're correcting them. So correction comes from outside of the body by us. Compensation occurs from inside the body or within the body, and that's how you check it.
Last question. Do you have a
Yep.
strategy to use when answering a priority or a ranking NCLEX question?
Yes. Okay. So priority setting questions as a general rule is something you all know how to do, but you all think doesn't work on the boards. Okay. So anytime you have any word that indicates priority, so priority first, immediately, most important, all those words that indicate a priority, just use the ABCs. Okay. Is there an airway issue? Is there a breathing issue? Is there a circulatory issue? Okay. Yes, yes, yes. That's priority. No, no, no. Go next. So after that, ABCs, then other physiological. So any physiological thing that doesn't have to do with airway, breathing, and circulation. So that's where pain falls. Okay. So pain is usually the next thing that you would prioritize. Okay. Pain is the fifth vital sign. It is not a psychosocial assessment. It is a physiological assessment. There is a physiological reason that we get pain. So ABCs, pain, and other physiological. So things that like hydration status or things like that. If none of those are good, okay, those are all fine. There's nothing wrong with the patient. Then you go to safety and security. Okay, so are there safety and security issues? So you see these a lot with patients who have psych mental health disorders and other issues where there's no physiological component at that particular time. If there's no safety and security issues, then you go to love and belonging, which are all the psychosocial issues. So ABC, other physiological, with pain being the first of those, safety and security, love and belonging. Okay. Then also actual comes before risk. So if someone has a risk for something, but an actual something else, the actual would come first. So for example, if someone had an actual airway problem, then obviously that's going to be first. But if someone had a risk for ineffective breathing patterns or a risk for airway issues, but they had a pain score of 10 out of 10 actual, then that's going to go ahead of their airway because the airway is just a risk and the pain is actually happening right now. And that's how you do them.
Thank you so much, Dr. Marshall, for all this great information. Sigma is grateful that you took the time to share with this audience and look forward to hearing more from you in the future. We hope you enjoyed this webinar. Be sure to check out Sigma's upcoming webinars, podcasts, and resources to support you and your colleagues. Also, previously recorded webinars and podcasts are freely available on the Sigma repository. Thank you for joining us and have a wonderful day.